You're welcome to this lecture on immune mechanisms and immunotherapy 4. Immune mechanisms and immunotherapy 4. I'm Dr. Akinyede of the Department of Pharmacology, Therapeutics, and Toxicology of the College of Medicine, University of Lagos. Before now, we did lectures on immune mechanisms and immunotherapy 1, 2, and 3. In the last one, which was immune mechanisms and immunotherapy 3, we looked at the innate and adaptive immune systems. We looked at immunosuppressive agents and agents that stimulate the immune system. In this lecture, we are going to consider vaccines, which are taken as substances which boost the immune system, stimulate the immune system against infectious diseases, and also have been used against cancer. For example, infectious diseases, viral diseases like hepatitis, like polio, have been countered with vaccines just to prevent the disease in people. And also, cervical cancer vaccination has been on for some years. That is to prevent the development of cervical cancer in people. After this lecture, participants should be able to illustrate immune mechanisms, work as part of a group designing a simple research to unravel a question on immunotherapy, suggest under guidance a pharmacological intervention in a situation which involves immune mechanisms. Today, we are looking at immunization, like I said earlier on. It can be active or passive. We need to note that when individuals come in contact, for example, with a bacteria, with a virus, that naturally the person's immune system senses that non-self, that foreign agent or foreign organism, and works at countering that. That occurs naturally, such that there is immunization. Sometimes it's lifelong immunization, sometimes it's immunization, natural immunization that just lasts for a few days, a few weeks, usually some weeks or months. So that if the person comes in contact with that organism again, the body recognizes it, it has learned the configuration of that organism, and the body will counter it, either reducing the virulence such that though the person manifests the disease, it is very mild, or may even prevent manifestation of the disease entirely. And it's the lessons from this that have been used to develop vaccines which have been useful in immunizing people. So immunization administered to people can either be active or passive. In other words, immunization can be divided into two broad classes: active or passive immunization. Let's look at active immunization first. What happens is that there is stimulation with antigen. The offending microorganism can be got, or part of it, or protein synthesized by it. It is administered, it is processed and administered as vaccine to the person, either oral vaccine like polio vaccine. It can be given as injection. The person's immune system will recognize it and produce antibodies against it, immunological defenses against it, so that if in the future the person comes in contact with that microorganism, it's either the person just suffers mild disease or does not suffer a disease at all. While passive immunization is done by obtaining pooled blood from people that have been infected with that particular disease against which you want to immunize. You get their blood, ensure that these are people who have formed competent antibodies against that disease, against that microorganism. And then the blood is processed such that the antibodies are got, and there is elimination of contaminants, including viruses, especially viruses like HIV, like hepatitis, that could cause other problems. And this passive immunization is now administered to the people that are most prone to coming in contact with that disease. This may be, for example, frontline workers. It was done about 4 years ago when Ebola was ravaging some parts of Africa. Administered to doctors and other health workers, and even administered to people that had contracted Ebola infection. The advantage of this is that since the antibodies are competent antibodies are being administered, it will help fight the infection, so that even if the person gets infected, it will be mild. The chances of making it will be more. If the person gets infected, in some cases, the person may not even manifest the disease. Sometimes this passive immunization is administered not just to people that have been infected, to people that may most likely be infected, like I said a few seconds ago, like frontline workers. Frontline workers can be administered the passive immunization. The difference is that the passive immunization works almost immediately. And this allows the survival of the recipient till either the body can build enough natural active immunity to counter the infection, for example, or an active immunization that has been administered can start functioning fully. Now, let's go back to active immunization. Active immunization is done by either taking a whole organism and using it as an antigen to be administered to a recipient. Sometimes the organism can be killed, so you have killed organism, and that is the antigen that will be administered. Sometimes the organism is not killed, but the virulence is reduced drastically. That we call attenuated live vaccine, attenuated live vaccine, or attenuated live organism. The reason is that some of these organisms are so virulent that if the virulence is not reduced, if it's not attenuated, the person can suffer from virulent disease, or there may even be fatality. Sometimes specific protein or peptide from the organism against which you want to vaccinate a person is got, a protein or a peptide. Whichever is appropriate that is got of these four. What happens is that the moment it is administered, the person's immune system senses it, recognizes it, and starts to form immunity against it. The immunity will do two things. It has the ability of killing the invading organism. It has the ability of suppressing the invading organism to the extent that even if the person suffers from the disease, as I said earlier on, it will be a mild form of the disease. The third thing it can do in addition, and that is what it usually does, that's the purpose for which vaccines are usually given, is that it prevents a future infection. Vaccines have been given this way to target infectious disease. I mentioned polio earlier on. Hepatitis is another one. There are so many of them. Some have even BCG. Some have been included in the routine schedules of immunization in various countries, which varies from countries to countries. Vaccines also target cancers. Anti-cancer vaccines have used all cancer cells or tumor lysis. The initial anti-cancers made use of that. The initial anti-cancer vaccines made use of all cells or tumor lysis. Now, these formed the antigen and relied on the antigen presenting cells in the host to process. So the antigen binds to receptors on the APCs, antigen processing cells, antigen presenting cells in the host. It will process it and present it to the immune system, and the immune system will now be activated and will now counter the cancer, killing the cancer cells. Second generation anti-cancer vaccines made use of APCs incubated ex vivo, that is out of the patient's body, with the antigen, and then reinfused into the patient. This is an advancement over the first generation system. DNA vaccines have also been used. The advantage of the DNA vaccine is that since it's DNA, there is no limit or almost no limit to how far the immune system will be able to react and produce, more specifically, the type of peptides and proteins needed to more effectively counter the cancer. The disadvantage of this is that the DNA can be incorporated into the patient's or the recipient's system, and that can be dangerous. That can cause genetic disorders. Cells have also been infected with different viruses, for the purpose of anti-cancer vaccines. Improvement keeps on being got as regards anti-cancer vaccines. Immunoglobulins are useful in patients deficient of antibodies due to congenital or acquired causes. Non-specific or highly specific immunoglobulins may be used. The immunoglobulin, like I said earlier on, is obtained from pooled plasma of adults and processed to eliminate infections, including viruses. We go into resource D immunoglobulin. Now, some individuals are resource D positive, some are negative. The positive ones have resource antigen in their on their red blood cells. The negative, those that are resource negative, have no or do not have resource antigen on their red cells. The implication is that those that have resource antigen on their red blood cells do not, I take that again, those that have resource antigen on their red blood cells, they are capable of producing resource antibodies. Now, mark you, if they produce resource antibodies, since they don't, I'll take that again. Those that have resource antigen on their red blood cells, they don't produce resource antibodies. Since they are resource positive, they don't naturally produce antibodies. Those that are resource positive don't produce antibodies. Those that are resource negative, they are capable of producing resource antibodies. Now, the problem is when mothers that are resource negative and therefore capable of producing resource antibodies get pregnant and their babies are resource positive. It means if the blood of the mother, if the immune system of the mother that is resource negative gets sensitized, the immune system will produce resource antibodies. These antibodies will attack the red blood cells of the fetus that is resource positive. It will attack the red blood cells of the fetus that is resource positive, destroying the red blood cells. Sometimes these babies come out with just jaundice. Sometimes the baby may even be dead before birth, So what is done is that all pregnant women have resource antigen testing. If they are found to be resource positive, that is not a problem. If they are found to be resource negative, it means it is necessary to give them resource D immunoglobulin. What that will do is that it will bind to the resource antigen so that it will bind so tightly so that the risk, that is, if the baby has resource antigen, it will bind to it and the immune system will not be sensitized by the antigen. So that's one form of passive immunization. Mothers that are resource negative, to prevent their immune system from being sensitized in case their baby is resource positive. You give them resource D immunoglobulin so that if the baby is rhesus antigen positive, the immunoglobulin will bind to the antigen so tightly and prevent the antigen from sensitizing the mother's immune system, so that the mother's immune system does not produce antibodies against the antigen in the fetus. Because if it does, it will destroy the fetus's red blood cells and can kill the fetus. Mark you, the use of passive immunization has been on for years, and it was used, for example, for people that were prone to tetanus. Maybe the person suffered a cut in the skin, and that infection, that wound is seen to be tetanus prone. They were given anti-tetanus serum, which was a form of passive immunization, so that will combat tetanus and prevent full-blown tetanus before the onset of action of the tetanus toxoid, which is active immunization, which they were given. You know, they will give them ATS and then give tetanus toxoid. ATS, anti-tetanus serum, being passive immunization. Remember, we said passive immunization works faster, you know, and then it will help reduce the seriousness of tetanus. It may even prevent tetanus before the tetanus toxoid, which is the active immunization, becomes effective. That one is more effective. The active immunization usually more effective, more specific, and the effect lasts for a longer period. And sometimes when someone has received just one active immunization, it gives lifelong coverage, protection. Sometimes you may need to repeat the injection once or twice, depending. Maybe because the herd immunity has been seen to drop in the society, or because of development of new strains, which may not be completely susceptible to the former active immunization given or to the single dose given. That's why, for example, polio vaccination, which was initially supposed to be just 3 doses to children in Nigeria within the first year of life, you know, had to be the schedule had to be changed. Children were given booster doses because the herd immunity had dropped and new strains were found in the children in the population. So next we look at HIV/AIDS and tuberculosis. These two diseases are influenced a lot by the immune system and also influence the immune system. Most people in regions such as developing countries where tuberculosis is found would have come in contact with the causative organism, Mycobacterium tuberculosis, before. What happens is that when someone that has the disease coughs or breathes into the air or sneezes, the person disseminates the bacteria, Mycobacterium tuberculosis. Now, someone else will inhale it, especially in places where there is overcrowding, you know, poor ventilation. Now, that bacteria goes down the lungs And if the immune system does not kill it immediately, it stays there. Inflammatory reaction, a chronic inflammatory reaction will occur around it. And as this occurs, you have lymphocytes coming around, and the bacteria is walled round so that it doesn't spread, it doesn't cause a disease. The person will test positive for tuberculosis. Such a case we describe as latent tuberculous infection. The person does not suffer the disease, no symptoms, but the thing is just there. The bacteria is there with the chronic inflammatory cells around it. If perchance the immune status of the person drops in the future, if the immune status drops in the future, this may be the drop in the immune status may be due to HIV, due to malnutrition, cancer, etc. What happens is that once the immune status drops, the disease, the bacteria can now start to grow again and multiply, and the person can develop tuberculous disease because the immune system is not containing it any longer. Now, if the person develops HIV, for example, HIV will attack the CD4 T helper cells. Now, these CD4 T helper cells are very important in that they normally activate B cells to produce antibodies. They cause macrophages. They cause macrophages to destroy ingested microbes. And they also enhance cytotoxic T cells, killing of target cells. So we can imagine that someone that has HIV who was in latent tuberculous infective stage, with time, with the decrease in immune function, will be susceptible to tuberculosis. If the person did not have latent tuberculosis before, once the person has HIV also, and the T helper cells function have diminished, subsequently, such a person, if he or she comes in contact with someone who coughs out tuberculous bacteria, the tuberculosis gets inspired into the lungs, the person is likely to suffer from tuberculosis disease. So these are ways in which HIV and tuberculosis interact. And that is why in a place like Nigeria, where we had, and other countries where we had quite a number of cases of tuberculosis before, with the advent of HIV, AIDS in the middle 1980s, we started having a resurgence of tuberculosis, even in cases where gains had been recorded against tuberculosis before. More patients started succumbing to tuberculosis. And in effect, we had worse cases of tuberculosis. And then patients with HIV also, who did not have tuberculosis before, or who had latent tuberculosis, developed tuberculous disease, or contracted tuberculosis. And tuberculosis will also weaken the immune system. It will weaken the immune system. So the cases of HIV were worse amongst patients with tuberculosis. Cases of tuberculosis have been worse amongst patients with HIV. And that's the importance of the immune system in these two diseases. Thank you for listening to this session where we looked at immunization. We divided it into active and passive. We looked at how passive immunization is carried out, how active immunization is carried out, including consideration of the antigens used, and we ended the session by considering the interactions between HIV/AIDS and tuberculosis. Thank you once more.